Welcome. My name is Nancy Seibolt. I'm a parishioner at St. Francis Xavier Church in Kansas City. Um, and I have been a physician in my day. I'm retired at this point. I was a family practice doctor for a while. I worked with the homeless a little bit. I worked in Kenya for a couple years. In the last 10 years of my career, I worked as a hospice and palliative care doctor. So I was asked to speak to folks about what is hospice and what is palliative medicine, and just a few of the a little bit of information that might help to understand what it is. So my job when I worked was to deal with people that were at the end of their life, and so I was present in both of these situations that you're looking at right now. These are people that are likely near the end of their life. And the one on the right um, is obviously in a hospital and probably in an intensive care unit. And this is pre-COVID because the nurse does not have a mask on. But nevertheless, you can see lots of tubes and machines, and you can see her with tubes in her nose and in her mouth and helping her breathe. She's probably anesthetized and not aware of all of this activity around her. And if you could hear this situation, you would hear buzzers and beeps. You would hear alarms going off. You would hear pressures in the respirator going up and down. And you can also see the focus of this woman, this nurse, who's taking really excellent care of her, focusing on fluids and machines and making sure that everything is taken care of with regards to all of this instrumentation. Now, the woman is there and she's comfortable. She looks comfortable. She looks like she's in the middle of a whole bunch of stuff happening. On the left is a person who's at home. We know that because that's the couch right behind his hospital bed. He's propped up on a few pillows and he's sleeping comfortably. He is tucked in with blankets that look homemade to me. There's some sort of a stuffed animal maybe sitting on his bed, as well as a card. So somebody's been visiting. Somebody has left him a card that he can look at, and I can see the house. The house is in a state of activity as well. There's medical supplies. I can see. You can just see pictures of family. You can see, nothing seems to be ordered, but there's a sense of real peace there. And I just show these two kinds of pictures to you to say that really at the end of life, a person has some power, some control, and some say, I should say, in how the end of their life goes. And some people really would prefer this home kind of situation, and some people really do prefer a different situation. And so we just have to keep that in mind. But both of these are illustrations of really the complexity and the wide range of possibilities that happen near the end of life. So I'm going to talk about what is palliative care, and I just like to look at the word origins. And it's really the word pal comes from actually a garment that was worn by the Romans and the Greeks, a cloak over their togas. And so the word comes from that origin of covering with a cloak. And palliative is, the definition is serving to cover or conceal to mitigate or to alleviate. You think of that word pall, which is the covering of a coffin at a service. So there's our Roman with his pallium over his toga. That pallium was used in its time to cover the horse before the saddle was put on there. It was used to bathe, to wipe off water from after bathing. It was used to hold babies. It was used to cover windows. It had a multi-purpose kind of character, and if you think of pallium and palliative care, you think of all the things that it could do to cover the situation. And I include a picture of Pope Francis because he is wearing this garment here, which he also gives to the cardinals, and it's called a pallium as well. So what is palliative medicine? If we understand that meaning of palliative being to cover, then I would say, this is my definition, is it as a branch of medicine, of study, of specialization that covers the issues around the serious illness and the end of life. I think of it like rehabilitation medicine. The rehabilitation doctors take a person after they've been diagnosed with a stroke, they have their neurologist involved, something's happened traumatically, and they take them at that point and try to see them as a whole person and deal with all of the issues that come up. So that's what palliative medicine really is. And this is a slide that I think makes a nice, a clear explanation of how these two things relate to one another. So there is a stage of medicine called palliative care, and there's also then a next stage of medical care that's called hospice care. They both have in common the very important goal of keeping people comfortable in no matter what situation they're in, through the illnesses and the symptoms that they have. Trying to look at the whole picture and reduce stress, trying to look at the whole picture of their bodies and relieve symptoms, and provide physical and psychosocial relief for all of the things that come up when a person is chronically or seriously ill. Palliative care can start at any stage, whereas hospice usually is meant to cover people at the last 6 months of their life. Palliative care can happen at the same time as curative treatment, whereas hospice really is that time of care when a person's options for curative treatment are really diminished or non-existent. And where it happens, really, it's either in the home or in a healthcare setting. And who takes care of them? Always the families involved, but more in hospice care, especially if the patient stays at home. So that's kind of a nice way of looking at what we're talking about here. This is a nice graph, I think, and I'm going to take some time with it to explain when all of these kinds of cares, medical care, happens. So if you start over here at 0, this is the time at which a person is diagnosed with a serious and maybe life-threatening illness. At that point, the focus of energy is in curative care, is in finding out first what's going on, and then you doing everything at that point to help. That's the time of diagnosis of cancer. That's the time of the hospitalization when the person goes into heart failure. That's when we're talking about here, when we're pulling out all the stops and helping them out. And you can see in the slide that palliative care can start at that time, but it's not really a big part of this care because there's the curative aspect is probably taking care of most of the symptoms, and it's so new that it's just it's a whole brand new thing that's happening. But as time goes on, and as possibilities for curative care diminish over time, then that's when the help with palliative care and symptom management can increase. And this gets to a point, it's not always a straight line, it sometimes goes up and down, but it gets to a point when curative care is just not either possible or, it's not possible anymore, or it's a decision that it's just that kind of care is too hard, is too stressful, is too much for a body to handle. And so a person decides that curative care may stop. And you can see at that point that palliative care is totally on board with that. And there's a switch then, because curative care is not possible or wanted, that hospice steps in. And this amount of time in here in hospice can be just a few days or a few hours sometimes, which is sad, to a few months. And we had patients actually that were qualified and on hospice for a couple years. So things can happen there. When a death occurs, then of course palliative care stops, and the next phase of care that hospice delivers, which is bereavement care and care around the time of death, kicks into action. So this is kind of how it all fits together in a perfect setting, in a situation which of course there is none. So I just added this slide because Medicare takes care of hospice patients, and there are very specific criteria for eligibility for hospice care that have to do and that are related to specific diagnoses. And so a lot of people think that hospice is only for cancer when the chemotherapy stops. But looky here, we're talking about heart failure. And so there are these criteria. You don't have to know very much, but I can tell you that it depends on a functional class. So we're not talking about people that are still up and around and doing a lot of things. And this is a functional class 4, means that you can hardly even sit up in bed without shortness of breath. We're talking about a measurement of your heart, this ejection fraction, which is less than 20%. You and I run around with 60 to 70. 100% is not possible, but 60 to 70 is normal. So other factors, rhythm problems that are really just not really well controlled with medication, history of having CPR and cardiac arrests in the past, history of fainting, a history of clot, and so you can see that there's very specific criteria. So this helps a doctor and a hospice to know when it's appropriate. Now, does that mean that everybody just goes on to hospice immediately when these criteria are met? No, it's still a person's choice. It's just that it helps us to know that if this disease progresses, as in our experience, if this disease progresses as it usually does in people, then we would be very surprised if they're still alive in 6 months. That's kind of what we use to make an estimation. Would we be surprised if this person is alive in 6 months? So here, this is just one. I'm not going to go through them all, but there's one for kidney failure. There's one for respiratory failure. There's one for dementia and Alzheimer's. There's one for ALS. There are several of them. And there's also one for failure to thrive. So then people that are really aged and infirm and frail, they talk about ability to walk. They talk about time in bed. They talk about infection rates. They talk about weight loss, and if a person's weight is very, very low. So all kinds of things. It's not just a person saying, oh, you need hospice. There's very specific criteria. So there's a lot of mythology. There's a lot of misunderstanding about hospice. And there's a lot of feeling around it. So we're very conscious of that, and try to be helpful in educating people around what hospice is and what hospice is not. And so if you look at these, they're all false, of course, but hospice is not where you go. It is a state of your being, and you may be at home, you may be at a hospice house, but when there's nothing more that a doctor can do. And then patients would say all the time, so there's nothing else you can do. And no, wait a minute. There might not be a curative um, um, treatment at this time, but there's a lot that we can do to help you to be comfortable and to help you to get to your goals. So do I have to be in the final stages of dying to be on hospice? No, and we would prefer it if you weren't, because we could help you out and understand it, get with your family and help them understand the process and do that whole covering without it having to be the last hours of your life. So quality care at the end of the life is very expensive. You could tell from the very first slide that I showed you that that's not true. If I choose hospice, I have to leave my home. As long as you're safe at home and there's someone to care for you there, then you can stay at home. Otherwise, there's other possibilities. So we absolutely involve families to care for people at the end of their lives. And it's, as I said, it's not just for cancer patients, not just for the elderly. I mean, unfortunately, babies and young people have illnesses that qualify them for hospice as well. And after the patient's death, that's just the start of a year's worth, really, of grief, counseling, and therapy that is offered to the family. So the other myths that I don't want to spend a terrible lot of time on, but morphine drips are there to help people to control their pain. It's not to kill them. The intent is, this is strong medicine, yes, and we will be very smart about it, yes, and we will titrate it and make sure that we take care of this symptom the best we can, and as we increase it, we'll talk. So there are no death panels. As a matter of fact, the panel that happened was, for me, was in the first visit when the patient really clearly was able to speak what their goals were and tell us what they wanted. So they were the ones that really directed us and navigated our care. A DNR means that no treatment will be given. A DNR means that if your heart stops, that somebody will let it just stop, that there will be no active treatment for that. But that doesn't mean that other treatments will be stopped. Hospice watches a person through time, and as their body deteriorates, they have this really elegant, the body has an elegant way of closing down with the gut slowing down, with the kidneys kind of slowing down. And so a patient's desire for food, if they want it, and if they can, if they have the plumbing to take care of it, you know, yes, they can have whatever they want. But usually they slow down, and if they need some water, then they can have some water. But it's usually a process, and nobody starves anybody. We always watch the patient. So that one of the really hugest, biggest myths that that we deal with is patients and people out there's understanding of CPR. And this slide is, you know, I used to love this show. So this is ER, and this is the 90s, and a study was done on medical dramas from the 90s. It showed that 75% of the time when these guys performed CPR on a patient on TV, it worked. And which means that a person woke up and was able to speak, and of course their makeup was okay, and their hair might have been a little bit mussed up, but it worked. So it would be reasonable for the TV watching public to think that CPR could be successful and people would be brought back from death to a healthy lives the majority of the time. Well, in fact, it doesn't work 75% of the time. It works about 8% of the time, and that's if a patient is in the hospital and is young and relatively healthy, um, and the care is immediate. So it's the other part of this uh, issue is that because there's been varying times that a patient's gone without oxygen, they probably don't wake up to the same level of functionability that they had before they had their heart attack or when their heart stopped. They've suffered oxygen deprivation, and they're probably not going to be able to return home to what they knew before. So that's a basic truth as well. We love you anyway, though, George Clooney. So the question is, life asked death, why do people love me but hate you? And death responded, because you're a beautiful lie and I'm a painful truth. So it's always a back and forth, but it's part of who we are. We're human beings, and we all are going to have an end. And so the question is, that comes up with hospice is, can we do something to move our care of you to a good situation or a good death? Is there such a thing as a good death? Sounds like an oxymoron to me. But think about it. Have you ever been around someone at their death? And how did it lean? Did it lean towards being a peaceful time of real grace, or was it difficult? And yes, there are difficult deaths. And so there was a study by the American Journal of Psychiatry, and it looked at what people's preferences were about the dying process. And so here's a list on the right of what people, if you could identify a definition of a good death, you would see dying during your sleep is on there, the second one. And a hospice nurse I work with said, yes, I just want to wake up dead one morning. That's like 90% of people would love that. And I would love that, actually. But there's a preference of it happening fast and quick and slick, with no pain or strain. So if there is a prolonged illness, then at least some arrangements for funeral and advanced directives, planning to be done. So a person with a good death does not want to be suffering, either with pain or other symptoms. A good death means emotional support, a chance to discuss what's going on with me, the meaning of death. It means having my family that I want there. It means that having that family around and accepting of my death and prepared and not feeling like I'm a burden to them. A good death means that I die as an individual with some independence and dignity. It means that I'm able to say goodbye and get all my unfinished business done, and understand and realize and be thankful for a life that was well lived. It means being connected with my spiritual roots and meeting with clergy sometimes, reconciliation, confession. Treatment preferences for a good death mean not prolonging life, mean don't get when my heart stops, let that happen. Let me have a natural kind of death. I don't want to have this diseased life continue. I believe that all treatments were used. We did everything we could, and I had a say over what I wanted. I'd like to be at home. I'd like to maintain some hope, pleasure, gratitude. Remember the slide in the first with the little guy in bed, and he has that little teddy bear or something there, just to have comfort and what I know as comforting to be around me. So I want to be trusting of my doctor, nurse. I want them to be comfortable with the death and dying process and be very smart and be very helpful with controlling my symptoms. And at the very bottom is I just would like a respect for my cultures. I don't want to be a financial burden. I want to have my puppy dog around. So if you think about what's important for you and what would make a good death for you, those are things that are crucial at the end of life. And it's really important to make them known to people that love you and that might be there. So the end kind of conclusion to this study was, if you want to know how to help a patient have a good death, then ask them what that means. And it just points out to me that communication is a real key tool of palliative medicine, and that the communication with the patient and with the family from the aspect of the care team is important, but also communication of the patient with their family and with their healthcare providers. And in a slide, a few slides back, when I worked with a hospice nurse, she said once to me, she loves this work because there's just no time for BS. And for me, that was a lesson in the time factor of dealing with patients that are near the end of their life. We don't have a lot of time, so let's get down to it. Let's find out what your goals are. Let's fix these issues that are bugging you and do the best we can to help you have a good death if there is one. So that conversation about goals of care is something that we would have with the patient right off the bat. And, assuming that they had, and maybe helping them to have, a clear understanding of what is going on with their bodies and what's possible. Knowing those things, knowing that this illness is going to increase in symptoms and it's going to eventually end in my death. So knowing those things as my reality, what are my goals? And usually when I talk to people, I can look at their faces and they're like, what are you talking about? Well, so some people know that they're dying, but they still want to see the grandchild that's due in 2 months, or they want to attend a graduation, or there's a wedding, or there's something that's happening that it's really kind of a good shot. They can have a good shot of making it to that point. So that's what their goal of care would be, is to make it to that point. And so that that oriented us as their healthcare providers to do aggressive kind of things to help them with their if they were still in palliative care, to help them to accept a curative kind of treatment, even if it was really hard, or go to the hospital, or to do things to keep themselves alive that long, so that they could make it to that point. And we saw it time and again when they would, Mrs. Smith would make it to the wedding of her grandson and then die a week later. So people have a way of kind of working and putting energy where they want it to be. This first goal of care, to keep pain to a minimum, well, that's just a no-brainer, right? Well, yeah, it is. Most people don't want to be in pain, and we have medicines to help that. The issue is that if your pain is at a point where it's really, really strong, then the amount of pain medicine that we may need to give you might make you not be able to be awake. You may be sleeping a lot and not able to have conversations or do your work if you have work to do. And so the conversation with that person would be, well, we could control the pain to this point and still keep you awake and alert. Is that okay? Yes, that's okay. I can bear that. So it's a conversation. It makes sense that symptoms are the same way: shortness of breath, diarrhea, anorexia, those kinds of things we could help with. So The other goal of care that we always instilled and made sure that patients were is safety. So we conversations about, now you need to move your bed downstairs, like the gentleman in the first slide. Why? I want to be upstairs. Well, for one thing, I don't know how often you're going to get up there, but two, if you fall, you're not going to be able to stay home. So why don't you just be safe to begin with? And those kinds of conversations would happen, and then people would come around and say, oh, guess you're right. Okay, let's put the bed down here. So goals of care is to allow meaningful interactions. Like I said, having some kind of balance between pain and symptom management and being able to interact, and to further to help with their spiritual, emotional well-being, to allow patients and caregivers to understand what's going on and express their feelings. The hospice care team that I was a part of included an RN and a nurse assistant, a nurse's aide that would help with bathing and other personal care, a social worker, and a chaplain. So we try to cover it between the team, the members of the team try to cover, like I said, covering is palliative care, all these things that are happening. Always looking at the burden on the caregivers and trying to assess that and to help the family to understand how important that is and how it needs to be maintained. So the last little bit here is just the interesting thing that I was looking at, and that is hospice care really didn't exist as a specialty before the mid-1900s, and it was because you think of it, hospice care takes care of people with heart disease right now and cancer and things like that, and just even a little over 100 years ago, the lifespan, the average lifespan was low. And look at besides the difference in race, we're talking about 50 being an old person in the 1900s. And why is that? That's because there were illnesses, and most of them were infectious. Infections, pneumonia, tuberculosis, etc., Spanish flu. Most of those things came on suddenly and killed you right away. So patients with pneumonia, there was no treatment for that, so they just got pneumonia and died at home. And so the development of hospice medicine has really happened over the last 50, 60, 70 years. Before the 20th century, medicine was kind of medieval, and I just took some pretty scary pictures here and showed you why it was so scary. But just look at, these are the developments in the years that they happened. An important one, these are the developments in the years that they happened, the things that changed medicine. All of these things absolutely changed medicine, and really caused or really set up medicine for the need for taking care of people through chronic illnesses and the end of life. And one over here, if you can see it, is Alexander Fleming in London, who discovered penicillin. And just think about that, how many times you take antibiotics. Antibiotics weren't available before the 1930s. And that discovery happened in 1928. In World War II, there were chemical weapons used. One of them was mustard gas. And so study of those folks who were exposed to mustard gas showed that their white blood cell count was very low. And so a very smart doctor, researchers said, we have these patients with leukemia that have very high white blood cell counts. I wonder if we gave them mustard gas, if that would help. And so the whole idea of chemotherapy came about in the 1950s. Even, we'll go right above it, this is an iron lung for polio. So not only do we have a vaccine in 1952 that works, before that, patients who weren't able to breathe were placed in these big iron lungs. Of course, we have now we have respirators and ventilators. But this wasn't until 1927. So if you had polio before that, you died of suffocation. Our good old friend Bayer aspirin in the late 1800s was developed for pain and has since been found, at least when I was still practicing medicine, if you were having a heart attack, you'd give the patient 4 baby aspirins to chew because of the side effect of this pain medicine, which is to thin blood. But it's now just standard of care, but only since the 1900s. Insulin was developed in 1921. This is down here in 1943. This is a dialysis machine. Right next to it is a heart and lung machine, which allows for doctors to open up the heart and do surgery on the heart, and yet the patient lives because there's this heart-lung machine. Over here in the corner is the development of X-rays, and up here on the right or on the left is CPR that was developed only in 1960. So that's a very recent development. IV fluids weren't given until the mid-1900s. So all of these things together mean that we have now a longer lifespan, and it has changed the way what causes death. So if we look at causes of death in 1900, the big portion of them were infectious disease and pneumonia, tuberculosis, even just a skin infection or a burst appendix. Any of those things were immediately fatal. Heart disease is there, cancer is there, but people didn't live long enough to have really long cases of cancer or heart disease. Plus, there wasn't any chemo. So if you got cancer, there were a few treatments, but not many, and you did not live. You did not have a 5-year survival. So all of those things just changed, so that we're looking at 2010 on the right, and we see that heart disease and cancer now, almost 2/3 of cases and reasons for death. And infectious diseases, because of our treatment with, this is just antibiotics alone, has just curbed the number of deaths from infectious diseases. And we have hope around COVID. But anyway, so this is why you can see in 2010, there's more opportunity for people to last longer and to have more chronic terminal diseases than in the early 1900s. So it's just a matter of need, really, that hospice and palliative care developed. So with that, I'm going to end with this quote, which is how most of us would prefer to handle the issue of death and dying. And as Woody Allen says, it's not that I'm afraid to die, I just don't want to be there when it happens. So just a thought. And I hope you enjoyed this presentation. And I really enjoyed this work. I felt like it was a real good fit for me as far as being able to communicate and be real with patients, and to have a relationship with somebody at a very important time in their life, and to witness the grace and peace of a good death. So thank you.